Welcome, everyone. Thank you for joining. We're about to start in a few minutes. We're waiting for a few more people to join. Hi, everyone. We're waiting for a few more people to join, so we'll start in about 2 minutes. Good morning, good afternoon, everyone. My name is Mande Limbu, Advocacy and Partnerships Director at FP 2030. Welcome to the consultation on the dual prevention pill, DPP, with family planning and SRH stakeholders organized in collaboration with AVAC, Clinton Health Access Initiative, and Population Council. Before we start, I'd like to make a few logistics announcements. Sophie, if you could move to the next slide, please. We do have French interpretation, so do please select your preferred language using the Zoom interpretation function. We ask that you please stay muted during the webinar, and please also disable your video as it may affect your connection. You should see a Q&A pod where you can submit questions. Please feel free to add questions in English or French. We will be recording this session, and the presentations and recording will be shared with you all after the webinar. Next slide, please. So we do realize that DPP as a new product has not been socialized enough among the family planning community compared to maybe the HIV partners. So many of us are probably coming to this conversation with limited knowledge about the DPP. Our main objective today is to socialize the DPP among family planning and SRH partners with the aim of building literacy, but also buy-in for the product within the family planning SRH community. We hope the discussion today will surface key concerns, questions, as well as unique perspectives and feedback from the family planning partners to ensure that DPP introduction plans reflect those perspectives in order to better prepare for its rollout. So Jessica Rodriguez from AVAC will start us off with an overview of the DPP in the context of multipurpose prevention technologies, MPTs. She will highlight progress to date and plans for research and development, evidence generation, and market preparation. This will be followed by a presentation from Barbara Friedland from Pop Council on the DPP in the HIV prevention and SRH landscape. Barbara will outline some of the key questions and complexities on understanding potential demand for DPP. We will then have a 35-minute discussion that will be moderated by Beth Frederick from Advanced Family Planning. This will be an opportunity to gather feedback on what family planning partners see as opportunities and challenges for the DPP, in addition to questions you may have for the speakers. After the discussion, Danny Edwards and Danny Reza from CHAI will present and facilitate a discussion on system considerations for DPP introduction. And my colleague Hima Patel will close our session with some key next steps. Next slide, please. So before handing over to Jessica for an overview of the DPP, we wanted to do a quick poll to gauge where we all are as far as our understanding of the DPP. My colleague Sophie will do her magic and hope the poll will pop on your screens shortly. Please take a minute to respond. What have you heard about the DPP? Whether it's nothing, today is your first time, or you know, it is a pill combining oral contraceptives with PrEP, or you know a lot, your institution, or you are working on the projects related to the DPP. So I'll give you a few minutes to respond to the poll. And Sophie, whenever you're ready, if you could launch the results.
Yeah, so I'll give them a few minutes to finish and then I'll end the poll and launch the results. All right, it looks like many people have filled out the poll. I'll go ahead and end it and launch the results. That sounds good to you, Monday.
Sure. Great. Thank you so much, Sophie. Thank you all. So based on these results, it looks like some of us have heard nothing or know a little bit about the DPP. So, well, I guess this means we are all in the right webinar and ready to learn together. So over to you, Jessica. Thank you.
Thank you, Monday, and thank you to FP 2030 for hosting this webinar on the dual prevention pill. I'm Jessica Rodriguez, Director of Product Introduction and Access at AVAC, the organization that leads the Dual Prevention Pill Consortium, and we're glad to be co-presenting with some of our partners on the DPP Consortium, including the Clinton Health Access Initiative and POP Council. And I'm excited to be here today to describe the dual prevention pill, a daily oral pill that combines oral contraception and HIV prevention, and why it can be a case study for future multi-purpose technologies. Next slide. As you can see from this map of East and Southern Africa with the areas highlighted in dark brown, there is a significant overlap between high unmet need for family planning and high rates of HIV incidence. From a public health perspective, a product that combines contraception and HIV prevention like the DPP can help address these multiple health needs that many women face. Next slide. From the user perspective, from the perspective of many women, as shown through discrete choice experiments and other qualitative research, many women may be more open to taking an oral pill that is a multi-purpose technologies. These studies show that women and even their partners would prefer using a dual purpose product that prevents HIV in pregnancy compared to one for a single indication. And in fact, most were willing to forego their preferred single indication product. In many cases, this was an injection for a less preferred formulation, like an oral formulation, if it offered dual protection. So what is the dual prevention pill? Next slide, please. The dual prevention pill is a fixed dose combination product that contains oral PrEP, tenofovir, and FTC, and a combined oral contraceptive. In this case, it's levonorgestrel and ethinyl estradiol that is being developed for commercial use by Viatris, formerly known as Mylan. Truvada and its generic equivalent is the only recommended drug for HIV prevention in women to date, and the only oral formulation recommended for women to date. And this combined oral contraception is the most popular form of oral contraception in many low and middle income countries. It is a co-formulated bilayer tablet with differentiated colors. dark pink for the first 21 days, and light peach for the last 7 days. The packaging will be a cold blister pack that is foldable with instructions for use printed on the back, and women will be able to tear off weekly sheets for ease of use and portability. The branding will reflect a women's lifestyle, and all of this, the pill color, the packaging, and the branding, really were selected based on end user research conducted in Zimbabwe and South Africa. Current regulatory timelines from Viatris suggest that the DPP could receive FDA approval by 2024. And longer term, Population Council and Medicines 360 have partnered to start development of a FTAF-based DPP. And FTAF is an alternative oral formulation for HIV prevention, which offers the possibility of developing a smaller pill that more closely resembles the size of oral contraception. Next slide. And to situate the DPP in the broader MPT landscape, and while the DPP is likely to be introduced shortly after new HIV prevention products like the Dipivrin ring and cabotegravir for PrEP or injectable PrEP, these do not provide contraception benefits. And extensive research has shown that HIV preventing pregnancy is a more top of mind concern for many women. And as you can see from the MPT pipeline graph on the right, multipurpose rings, injectables, and implants are in much earlier phases of development and not expected to be available for many, many years to come. Next slide. The DPP will help pave the way for future MPTs. Combining 2 approved products speeds up time to roll out and impact. Bypassing a large clinical trial and building on existing lessons from the infrastructure for family planning and oral PrEP, the DPP really presents a learning opportunity to facilitate introduction of other MPTs in the pipeline. It can also offer an opportunity to break down long-standing silos between HIV and family planning delivery channels. And integration may be easier and may be facilitated by a tangible product. In addition, with increased interest in integrated solutions and self-care, the DPP has the potential to attract a wider array of funders for HIV as well as broader sexual and reproductive health. Combined use could lead to better health outcomes. One pill makes the DPP more inconvenient and could possibly motivate women to sustain uptake and continue to use the product for longer compared to using both products separately. And finally, the DPP is a woman-controlled product, affording women agency to mediate and negotiate its use. And as we've seen, it's much harder to do that with male and female condoms and to negotiate the use of male and female condoms, the only other MPT available. Next slide. So who is the DPP for? Early adopters are likely to be women who are familiar with oral contraception and oral PrEP and have used either both or either or who are new to using oral PrEP and oral contraception. While the DPP likely will be for women ages 18, 20 to 40 of reproductive age, we are hopeful that it will also be used by adolescents and young women who do experience disproportionate rates of HIV incidence in particular. Female sex workers and postpartum women will also be considered as well. And ultimately, governments will determine the priority populations based on their context. And it is also important to note that women on long-acting reversible contraceptions who are satisfied with their current method will not be a focused population for the dual prevention pill. Next slide. What makes the process for regulatory approval different for a product like the dual prevention pill, where both products have been previously approved by regulatory authorities is that it requires a bioequivalence study, which is much smaller and much faster compared to larger clinical trials. And it is the most pursued pathway for the approval of any generic drugs. And we are excited because we're really hopeful that initial pilot bioequivalence results will be available in the next few weeks. As I mentioned before, regulatory timelines from Viatris suggest that the DPP could be available and approved by the FDA in 2024. Viatris plans are to file also directly with the national regulatory agencies in priority countries such as Kenya, Zimbabwe, and South Africa. Again, because these products have been previously approved and recommended by the WHO, there is the possibility of expedited review where the WHO would issue a technical brief, and there has been some precedent for that in the past. Multiple studies will be conducted and are underway in these prioritized countries, which will help to build a really cohesive body of evidence required for country-level regulatory approval. And phased country-led introduction plans are in development with broad stakeholder buy-in and input. Next and final slide. So where are we in terms of the process for developing the market introduction plans and strategy? We have made significant progress, as I've mentioned. The product design has been conducted with end user input. Pilot BE study is in progress. And we hope to then proceed to the pivotal BE study as well as secondary packaging. End user research has been conducted and will be also strengthened and reinforced and taken to the second phase, as well as acceptability studies with an over-encapsulated form of the pill and a co-formulated pill is also currently being conducted, not only with women and potential users, but with providers and their partners. We have a draft market preparation and introduction strategy, and we have engaged civil society extensively and formed an advisory group of civil society members, young women, and advocates who are inputting along the way throughout the process. And we do hope to also develop country-level roadmaps to detail and outline the introduction of the DPP in various countries. So we're really excited to hear from all of you, to hear your concerns, the potential benefits of the DPP, the challenges, to hear your questions, and look forward to an interactive discussion in a few minutes. Thank you again, and I'll hand it over to Barbara Friedland from the Population Council, one of our key partners on the consortium.
Good morning, good afternoon, good evening, everybody. I'm trying to start my video, but it's saying that I can't. So I'll just start talking, and at a certain point, maybe I think one of the co-hosts has to open it for me. So I'm Barbara Friedland. I'm a senior associate at the Population Council at our Center for Biomedical Research. And I'm here today to talk with you about the DPP in the HIV prevention and sexual and reproductive health landscape. The Population Council is conducting acceptability studies of the DPP in South Africa and Zimbabwe. And as part of the preparing for these acceptability trials, we conducted formative research with stakeholders in those countries, primarily end users and healthcare providers. Next slide, please. So some of the most common questions that we've been hearing so far are, will there be sufficient demand for the DPP? Could the DPP jeopardize progress on long-acting reversible contraceptives? And will counseling on the DPP confuse providers and negatively impact family planning programs? Next slide, please. So we believe from the evidence that we have seen that there is indeed a market for an oral pill that is a multi-purpose prevention technology. As I think probably you all know, 65% of new HIV infections in adults are among women aged 15 and older in East and Southern Africa. And within this population, there's a subset of women who continue to use oral contraception over time. Even with the introduction of new technologies, OC use has remained relatively stable across countries, excuse me, within East and Southern Africa, as well as across Sub-Saharan Africa more broadly. Meanwhile, oral PrEP is being scaled rapidly in many East and Southern African countries as well. In just 5 years, initiations have grown exponentially across the same countries. Next slide, please. So the Population Council conducted a desk market research study, meaning we looked at data that were available publicly, and looking at estimates based on people who were currently using oral contraception, using condoms, or had an unmet need for contraception. We estimated that in 15 countries in Sub-Saharan Africa, 250,000 to 1.25 million women per year might use the DPP, and 5.4 million HIV negative COC users were in just those countries. So we feel like this was a conservative estimate. So if you look at this chart, the blue bars show the current PrEP users. This data is a little bit outdated because it's from a couple of years ago, but the blue data is men and women together. And one of the things that was tricky about our analysis was trying to tease out how many women were on PrEP versus men. So then the numbers in the orange bars are 250,000 versus 113,000. It's actually more than double the number of people currently on, number of women currently on PrEP, as the blue bar represents everybody. Next slide, please. So I think, as all of you know, method switching is very common over the life course. When programs provide information on the possibility of switching, women are better informed about voluntary family planning, choice, and their options to continue when a method is not suitable. A recent study by Jane et al. From the Population Council found that modern method discontinuation 3 months after method initiation is lower when women receive information about method switching as part of method information. So the DPP could actually expand choice and voluntary uptake of family planning to better meet women's needs. As Jessica mentioned before, women who are using LARCs, which could include injectables depending on how people categorize them, and are satisfied with their method, should not be encouraged to switch to a less effective method, but they should be offered oral PrEP, male and female condoms, the Dpp ring, and CAB-LA as that gets rolled out. But women who are not using LARCs or who are not happy or satisfied with their marks should be offered an array of methods that meet their needs. Next slide, please. I see people saying that they cannot see the presentation, so I don't know if that's widespread. Okay, you can see it. Okay, great. So what is going to be needed once the DPP is available? So family planning providers are familiar with counseling on informed choice and explaining risks and benefits of various methods. So they will have a new method to add into the mix, but they'll be used to the type of counseling that is needed. The tricky thing is that the DPP counseling recommendations will need to align with oral contraceptive and PrEP requirements, for example, on missed pills, which are not exactly the same. And to that end, the DPP consortium has a subgroup working on counseling messages to really look at the evidence for guidance on missed pills, how many days one needs to be taking the method before you can stop using a backup method, etc. And so basically the provider counseling subgroup is developing initial recommendations, which we will be incorporating into our acceptability studies, which will generate evidence on these counseling messages. And lastly, we need to understand provider attitudes and motivations toward providing the DPP and ultimately other MPTs, and support and what support they need to ensure quality service provision for an expanded method mix. Next slide, please. With that, I would like to thank everyone and turn it over to Beth Frederick to moderate this discussion. Thanks, everybody.
Thanks, Barbara. Well, you have a few questions right off the bat, so I'm going to start with those. And one of them is that it was mentioned that women using LARC will not be considered key populations for the DPP. And what about women using injectable contraceptives? It's from Jennifer Mason at USAID. So that's your first question.
Great, thank you. So I think that it's a tricky question in the sense that the individual women will have autonomy to choose products that work for them. That being said, if people are successful and happy with a long-acting method, they would not be, our recommendation would not be to encourage women who are successfully and satisfied users of LARCs to switch to this method, but rather encourage those women to use oral prep or condoms, depivorine ring, CAB LA. However, as we also know, a lot of women may not be happy with a LARC, or they may be in a different situation where the LARC is no longer appropriate for them wherever they are in their point in life. And women who are using injectables, I will put into that category as well, may not be satisfied with the method and may be interested in using something. So, you know, on an individual level, women should have the choice to use whatever works for them, but on a population level or on a policy level, we would not suggest recommending the DPP for people who are successful and satisfied LARC users.
So Barbara, another question from Jennifer looks at why Zimbabwe and South Africa were the sites for the acceptability studies and other research.
Great question. So Zimbabwe was the first place that we plan to do research on acceptability because they have a very high use of oral contraception. And since our belief is that the early adopters will be people who already use oral contraception, it seemed like the natural place to do the study. About half of women using modern contraception in Zimbabwe are using oral contraceptive, and it's one of the highest places in the world of oral contraceptive use. And they also have high rates of HIV. So that was a natural place. Then the choice of South Africa was because they have very high rates of HIV, and it's a place where oral contraceptive use is not as common. So we wanted to do our studies in places where there were different backgrounds of HIV and oral contraceptive use to see how it would fare in different settings.
Thanks, Barbara. So just a note for everyone who's on the line with us, we're now 132 strong interested in this, in DPP. We also want to hear what you think are some of the challenges and opportunities for this method. So put that in the chat as well as questions for the two panelists, and we'll try and have a dynamic conversation as we go along. But Jessica, there are a couple questions for you now. Have ministries of health been consulted yet? And that's from Ravina Chowdhury at MSI Reproductive Choices.
Yes, thank you. Great question. So yes, in late 2019, DPP consortium partners traveled to Zimbabwe, Kenya, and South Africa to consult various stakeholders in country, including the Ministry of Health, including regulatory agencies, implementers, a wide range of stakeholders to really sort of assess what were the challenges and benefits of rolling out a product like the DPP from different perspectives, from the regulatory perspective, from the delivery perspective, from the demand generation and marketing perspective, and that those inputs were vital into drafting the initial market introduction strategy. And late last year, in November 2021, we had a consultation with led by the Ministry of Health in Zimbabwe, where there's high oral contraceptive use, to discuss the DPP in more depth, to discuss the R&D timelines, and to carve a pathway forward. And we'll be re-engaging once B results are available as well, to draft country roadmaps for introduction.
Yeah, that's a lot of work coming up, I think, for all of us, actually. Jim Pickett's asking about the potential plans for the United States. And there's often a disconnect between our work with other countries, and then we lag behind when it comes to here at home. So what would you say to that, Jessica?
I would say absolutely. And late last year, AVAC, Pop Council, and Jim also co-hosted a webinar where the DPP was featured in the context of other multi-purpose technologies for women in the US. And as he rightly notes, cisgender Black women have been left behind, particularly in terms of HIV prevention. So absolutely, the DPP is a product that could be used by many women in the United States, and really hope that we can continue that discussion and really partner with people who are working on these issues already, to develop a way forward for rolling it out.
I'm going to stick with you again. I hate to put you on the spot, but there are a couple other questions that I think are related. Mm-hmm. One is the potential for private sector commercialization of the product, and also if manufacture of the product within India. True Overholt of DKT asked the first question, and Safia Hassan asked the second about India.
Great. So in terms of the private sector commercialization plan, we are in the process of developing a private sector delivery strategy, which will include commercialization. So we're still at the early stages of that. And you'll hear a bit more perhaps about the cost of the product from Chai in the next presentation. But one of the challenges is that the delivery of oral PrEP in the private sector is not as advanced as the delivery of oral contraception in the private sector. So really aligning that and thinking through ways to align those delivery channels will be really important for the DPP. And I think encouragingly, we're seeing more and more that oral PrEP is offered through pharmacies and through the private sector. But it is lagging a bit behind oral contraception. But happy to also hear from DKT and work with DKT on a commercialization plan. And I think initially, yes, it will be manufactured in India, but as we understand demand more, as we understand the supplier base, it could expand, but those are the plans to date.
So a completely relevant question for Barbara on this about market size. So this is from Megan Christofeld of Japigo. When you estimate the market size for DPP, are you anticipating pulling DPP users from existing oral PrEP users, or are these completely new to PrEP users? Is that clear enough, Barbara? I know it's got a lot in it.
Yeah, it is a clear question. The answer is less clear though, because as I mentioned on the slide, when we were trying to figure out how many people were using PrEP in the country, in the 15 countries where we did our market estimate, we could not tease apart how many were women and how many were men. So the data are just not there to be able to pull apart. And so in theory, we could be pulling from people who are currently using PrEP, but our conversion rates were based on oral contraception, condom use, and unmet need. And those people could potentially also be PrEP users, but that data was not figured into the market estimate. I hope that answered the question.
Megan will tell us if it didn't, I'm sure. So Megan, there's your challenge. So another related question, is there any evidence of male contribution in the acceptability study findings so far? And additionally, any age difference in young versus older females? And that's from Roger Sesebunya.
Great question. So we have not interviewed men directly, and so far we've only conducted the formative research, which is in-depth interviews with providers and focus groups, and we're about to start 2 crossover acceptability studies where women will actually be using the co-formulated, the over-encapsulated tablet, but that is only going to be, so we have no data from that yet. But from the data that we have so far, younger women, and I believe Jessica mentioned this earlier, younger women are often more concerned about unintended pregnancy than HIV. And that was a very interesting finding from both countries. Again, this is not all women because different women will have different concerns, but it was a very interesting and common finding. And although we didn't interview men, all of the participants in the focus groups talked about male partners and how they would need to engage them, et cetera, in the taking of the DPP. And in particular, people felt that married women would have to have the support of their partner. They couldn't just do it on their own. So there was some discussion of a difference between married women and unmarried women. Thanks.
So for both of you, this is a really important question that we're all answering all the time on all sorts of contraceptive methods and PrEP. What are the side effects of the dual protection pill?
So
and this is from Serafina Lugarwa.
Okay, Jess, is it okay if I start?
Sure.
Okay. So just to say that from what we know, which is that WHO and CDC recommend that PrEP and oral contraception can be taken together, and there's no evidence of drug-drug interactions. So that's just, you know, a very positive piece of information. Both tend to have similar common side effects, so headache, nausea, vomiting. So those types of things are fairly common for both of them. And then I think that the rarer side effects are different for PrEP and COCs, but taking the two together in one capsule or one co-formulated tablet should not be any different than taking the 2 pills separately, which is currently recommended and fine for people to do. I don't know if that answered the question.
Do you have anything to add, Jessica?
No, I think Barbara captured it well. And one interesting finding from the end user research, if I'm not mistaken, was would combining the pills, combining the products really intensify side effects? So that is a question that many women had. Our hypothesis is that it won't, but we are still waiting for BE results to confirm that and confirm the side effects once combined.
One of the things, yeah, just to say, one of the things that we're doing in our acceptability studies, we're enrolling only people who are already oral contraceptive users who've been using OCs for at least 3 months, to try to get at some of that information, because if they've already been using OCs, hopefully they should have gotten over the hump or gotten used to those side effects. So then adding PrEP, onto that will help people know, okay, it's not much more, or it's the same as what I experienced before.
So Monica Kerrigan's asking an interesting question to both of you. Were there any surprises in the end user research? Is there anything that surprised you as you were going through this?
One thing that did surprise me and that was really interesting was that women wanted a product that would enable them to be discreet when using it, but also kind of didn't want to have to be discreet and wanted there to be much more greater acceptance in their communities and by their partners in using a pill that would prevent both HIV prevention and pregnancy. So that was one surprising finding, and how to balance that tension. And hopefully as we develop the marketing and demand generation strategy, we'll be able to dig a bit deeper to understand that better and to enable women to use it more openly.
How about you, Barbara? Any surprises?
Yes. So, I mean, I think that we've heard before that young women feel that they're not treated very well in family planning clinics or HIV prevention clinics, particularly, adolescents, young women, and there's a lot of judgment, etc. But what was very interesting to me, to us, was that not only did the women say that, but the healthcare providers said. The healthcare providers themselves said, we tend to be very judgmental, and so they this was something that wasn't about the DPP. It was about young women's reproductive health in general. And it was fascinating that they were talking about how things need to change and their attitudes and behaviors. And so that was very, very interesting finding.
So Getachew Bekele asks a related question about why the targeted lower age limit is 20. And why, whether there are plans to go lower in terms of provision to adolescents.
The age limit of 20 is really based on feedback from country level stakeholders, that it would be hard to lead or prioritize adolescent girls and young women due to stigma. Now, that is not set in stone at all. And so again, hearing from all of you that this is a product that should be available to adolescent girls and young women is really important. When we first conducted the country assessments in late 2019, there were some fears that by leading with or prioritize adolescent girls and young women, that it could cause some backlash. However, and also what we're seeing is that older women, there are higher rates of uptake of both oral PrEP and oral contraception among older women. But that does not mean that it will be limited or only exclusively available to older women. And Barbara, maybe you can talk about the acceptability studies and the ages of the women included in the acceptability studies.
Great, thanks, Jessica. Yes, so we are doing both of our acceptability studies are using an over-encapsulated, so it's not the co-formulated final version, but in those studies, the low end of the age group is 16 in both countries. And in Zimbabwe, it's a very small study and it's focused on adolescent girls and young women. So the age in that study is 16 to 24. And then in South Africa, it's a slightly larger study. And there we're going from 16 up to age 40. I think when Jessica was speaking before about, introduction efforts and, mentioned the age of 20, as she said, that's based on stakeholder guidance, but that's not what's going to be on the label. So it's not like it won't be available for or problematic for anyone younger to use it, because the label will be the same as what it is for PrEP, which goes based on weight and oral contraception. So those kinds of decisions about targeting age groups are not going to be a label issue, just to clarify.
And Barbara, maybe you or Jessica can answer this quick question from Baker Magua. Will you need a prescription for DPP, or will it be available over the counter?
I'm pretty sure you'll need a prescription for it, at least in the beginning. And in the United States, you need a prescription for oral contraception. So you definitely will need it here. Although many of us are working to not have that be the case. But I think, yeah, in the beginning, for sure, it'll be OTC. It'll be a prescription.
So the next group of questions are practical questions about introduction of the method, and they look mostly like they're for Jessica, but I'm not exactly sure. So looking at the introduction pathway, are we linking DPP's introduction with other FP products, new and underutilized, or will this have a parallel initiative? This is from Guattari and Durango of Chapago. So I think it's asking about whether it will have its own lane or be integrated.
Integrated with other family planning products?
Yep. Are we linking DPP's introduction with other family planning products, new and underutilized?
I mean, I think it's a great question, and one I would love to explore after this call. Because it is a multi-purpose technology, it might have its own lane because it is slightly different and combines HIV prevention, but would love to hear more about what new products are being introduced that it could be offered with as a part of informed choice. We are really hopeful and looking to be able to offer the DPP in family planning clinics. So I would say that that's as part of informed choice, along with other family planning methods, so that women are, as Barbara said, having the autonomy to make the choice that is right for them, which might be different at different times in their lives.
Yeah, it's making me think that there's a lot of work to be done on making this adhere to some of the counseling guidelines and be part of the broader set of counseling issues. Barbara, you have a thought?
Well, this is what occurred to me, and I'm not sure if it was an exact answer to the question, but I think our hope is that the DPP will be something that can help with family planning and HIV integration, which has been challenging for many years. And, you know, some areas are able to do it more successfully than others, but I think we see this as an opportunity to integrate family planning and HIV. And as the first MPT, that most likely the first MPT that will be available could lead the way for other MPTs entering the same combined integrated FP HIV setting.
So here's a long question, and I'm not sure I understand it all. So listen carefully. This is from Abdulamin Saad at the Gates Foundation. So HPTN 082 reported declining PrEP adherence in South Africa and Zimbabwe over time, within 6 months. Adherence is also a challenge with oral contraceptives. So here's the question. How would the DPP introduction address adherence and potential unintended consequences that may result from suboptimal adherence?
So our thinking is that there are many reasons why women discontinue using PrEP, ranging from stigma to not feeling like they're at risk anymore, etc. If someone is already a successful OC user and now they're taking a product that also includes PrEP, our hope is that it would improve the adherence to PrEP. So that was actually one of the rationales for putting these two together. And in terms of OC adherence, while it's true that there are people who struggle with adherence. There are also people who are very successful taking oral contraception successfully and avoiding unintended pregnancy for many, many years. So I think I think that the DPP can help, as it has two indications, but I think that there are certainly people who are okay taking a product every day, and then there are others for whom that is not going to be a successful regimen.
So Dove Gillespie is asking a somewhat related question on whether the messaging during the rollout will be different in populations with high, moderate, or low HIV acquisition, and whether you're going to, how you're going to address stigma in moderate and low populations.
That's a great question. And clearly we would prioritize locations with high HIV incidence in terms of the public health impact. And as I showed, I think earlier in the slide, that there are clear locations where there is high unmet need for family planning and high rates of HIV incidence. And those likely will be prioritized for introduction. And we are in the process of conducting end user research to look at just that. What are the messages based on women's input, their partners' input, provider input, for different geographies, for different subsets of women, those who are familiar with oral PrEP and OCs, those who are new to using these methods, to really get at the nuances as we develop approaches for demand generation. So we're in that process right now and happy to share those findings once available.
How will HIV testing mesh with all of this? And women, this is from Martha Brady, women on the DPP should continue to have periodic HIV testing. So what's your thinking on that, Barbara? Go ahead.
Yeah, so that is probably one of the most, the trickiest things at the moment, because although we believe that there would be a place for the DPP in the family planning setting, doing quarterly HIV testing is not something that is routinely done there. So wherever the women are going to be getting their supply, because as we mentioned, they'll need a prescription. So whether it is from directly from a provider or from a pharmacy, they will need to have an HIV test along with it. We are conducting some studies or planning some studies where we're going to look at self-testing to see if that could facilitate uptake. But it is definitely something that needs to be figured out in this context.
And Jessica, there may be an easier question. Is there enough production to meet demand? What's your plan for that?
Yeah, I mean, I think it is really too early to say what the demand will be. And once we have that more defined, I think we can say whether supply will meet demand. But we are aware that this could be a niche product and really appealing to a subset of women, and are confident that the supply will be able to meet the initial demand. And of course, the studies that are taking place now will help to inform that. And I did want to add on to what Barbara said about testing, which is what is encouraging is we are seeing more and more policies that support multi-month dispensing of PrEP every 3 months, which would at least align with HIV testing requirements and hopefully align with multi-month dispensing and scripts for oral contraception, making it a little bit easier to adhere to the HIV prevention requirements for the DPP.
There are a couple questions or maybe more comments in the chat about method switching. One related to long-acting reversible contraception and the other to condom use. So I think that there is some speculation that maybe there will be some effects of method switching related to use of DPP. What's your thinking on that? Either one of you.
Sorry, I'm not sure I totally understand the question. What kind of effects are people concerned about?
Let me read this one. While appreciating the choice, autonomy, and agency that DPP will offer women, we sincerely hope that the health systems will not push potential users to switch from more reliable contraception, example LARCs, to this one. What modalities of SBC and health provider capacity strengthening do you see being used in the scale up? And that's from Guattari and Durango. I feel like I'm
I don't know, Jessica.
Panelists.
No, I think, I think as Jessica said, the initial emphasis and rollout will focus on people who are already OC users or condom users or have an unmet need for contraception. And, we, the people here, will not be in control of ultimately the sales, the marketing, and the rollout of the product. So what we are trying to do is to recommend who should be the, as we call it, low-hanging fruit, to whom it's offered first. But if women end up hearing about it and they're interested in it, then they should be able to use it if that is something that they feel will work for them. So again, there will be, I'm sure, a disconnect between policy and systems and individual women. I think that, somebody asked before if there were things that we didn't expect to find. One of the things that I was surprised at was, because I know that injectable contraception is very common in South Africa, was I didn't expect to hear as many negative feedback about it. And I think, it's what they know, but it's not necessarily what they like. So I don't know how to answer the question any better.
It's okay, because we're gonna wrap this up.
And can I,
It may
go
have
ahead, Jessica, and then we've got one more question, and then we're gonna wrap it up.
Yeah, and I'd just like to add to that. I think, as Barbara's saying, there certainly can be bias in terms of counseling, and can be, from the provider, but also from just what is available in the supply and stock outs, and that really can limit choice. But I think the goal is to situate the DPP in informed choice and shared decision-making between the provider and the client. I think that's a lesson that family planning has really learned over the years. Hopefully we can situate the DPP in informed choice and not pitting, one product over the other or promoting one product over the other.
I think, to be fair, Jessica, in looking at the questions, it was concern about possible increases in STIs with condom use, and possible increases in unintended pregnancy with a switch away from LARCs. So the final question to both of you is from Chelsea Polis. What do you see as one challenge, one opportunity going forward? And then we're gonna close this session down, and I'm gonna hand it over. What do you think, Jessica?
I think a large potential benefit is really through a combined product, meeting two dual health needs and primary health needs of women in a way that is more convenient and hopefully more integrated. We've seen too many silos between HIV and family planning, and really is an opportunity to help, like I said in the beginning, really break down those silos. And we are seeing that there is higher both oral PrEP and contraceptive uptake when they are offered together. There have been a few studies in Kenya and South Africa in particular that have shown that, so those are very encouraging. The challenge will be exactly that. It's sort of the converse, how to align delivery of oral contraception, which is much more community-based and decentralized and differentiated compared to where oral prep is now. But we are seeing very positive trends. So really hopeful that perhaps the DPP can accelerate that.
Barbara, quickly.
Sure. I think an opportunity is this is the first MPT that will be out there, and I think we'll have a lot to learn from the introduction of a product that provides both HIV, the first MPT besides condoms, that has the potential to provide women with both of these protection from both HIV and unintended pregnancy. So I think that is really a very big opportunity. And I think the challenges are ones that we've already been talking about. So I don't think I need to go into them.
Well, thank you
Thank
both.
you.
Thank you, Barbara. Thank you, Jessica. Thank you, everyone, for your excellent questions and comments. And I'm going to hand it over to Danny Edwards and Danny Rassar and Nandi Lutuli.
Great. So good morning and good afternoon to everyone. Thank you so much for joining today. And thank you to AVAC and FP 2030 for having me on this webinar. Just quick check, everyone can see slides and hear me properly. Okay, great. So next slide. As part of the Dual Prevention Pill Consortium, we at CHI, Clinton Health Access Initiative, have been thinking through and engaging on different system aspects that will need to be considered and addressed to provide for smooth and timely DPP introduction. So today we're going to do a mini deep dive into two of these. First, monitoring evaluation, and then I will turn over to my colleague Danny for procurement. Next slide, please. So today I'm going to provide a very brief overview of the analysis that CHI has led to understand considerations for supporting effective M&E for the DPP, and to the previous question we ended on, other MPTs. Next slide, please. So to begin with some framing, we are looking at M&E systems from a few different lenses. So for example, as you can see on the left, we are considering the different time periods during a product's introduction pathway. With a new product and a new genre of products as MPTs represent, we know there will be significant evidence needs in the beginning, so it'll be important to consider the enhanced and often partner-led M&E mechanisms, as well as the longer-term sustainable routine M&E systems. And when we move into early insights, we've incorporated this concept of different time-bound considerations by breaking out insights into early implementation and introduction. So then looking on the right, we've pulled out a view of some of the different stakeholders who will have different types of M&E needs throughout the introduction process. So for example, it will be important to ensure that providers are not overburdened with data collection needs in the long term. Next slide, please. So to understand needs for the DPP and other MPTs, we reviewed the strengths and weaknesses in HIV prevention and family planning M&E systems as a first step. And in doing so, it's important to understand the broader history of these systems, which we've highlighted on this slide. So one overarching theme here is that family planning M&E is much older and more mature. So they've had more time to iron out some of the challenges that we're currently seeing in HIV prevention, which will provide an excellent opportunity for HIV prevention moving forward and for family planning. So for example, in terms of the method mix, in family planning, there's already a lot of really excellent experience in offering users informed choice, certainly places to improve upon, but a place where learnings will need to be pulled. because in the HIV prevention side, we're really just starting to look towards a multi-product menu. And of course, there's significant unmet need on both sides. On the HIV prevention side, we're really far behind global goals, with 1.5 million new infections in 2020 compared to a goal of 500,000. And women bear a disproportionate burden of new infections, which I think you've heard in a few other presentations today. And this strengthens the argument for the need for a product like the dual prevention pill. Next slide. So for approach on this analysis, we looked at 6 elements of M&E systems shown on the left here, which were adapted from a USAID measure framework. And we mapped strengths and weaknesses across both HIV prevention and family planning M&E systems for these elements. And this then informed preliminary insights for adapting M&E systems for the DPP, again, for each of these 6 elements. And then looking to the right, we identified strengths and weaknesses by reviewing a wide range of literature, including both HIV prevention and family planning guidelines across the 3 countries where DPP work is focused, as well as global guidance, databases, tools, and published literature. So we do include country-level documents in this analysis, but really at this point, we're more at an entry point into further country-level analysis needed, which I'm looking forward to getting into in discussion. Next slide. So just to provide a rapid overview of some of the key insights we've identified so far, I'll walk through a few of these at a high level. So for data availability, we know that based on family planning and HIV prevention systems, that we will not have easily available comparisons on areas like adherence and continuation through existing systems. So this is an area that we need to think about evidence generation for implementation projects. And then as we move towards early introduction, a key for ensuring ongoing data availability will really be ensuring a clear understanding or mapping of the requirements and processes to include new indicators in existing M&E systems. Moving down to data utilization, a key enabler during early implementation projects will be the continuous information sharing and co-ownership of objectives between governments and partners, even when many processes during early implementation projects may be partner-led. And then in early introduction, it will be really essential to ensure that there's clear ownership over these processes across HIV and family planning stakeholders, as indicators are not currently integrated across most countries, so we'll have to sit in one area or the other, which I'm happy to dig into further in discussion, as I think we've already had a comment about this in the previous session. So finally, for personnel and training, we've highlighted the need to support training through national systems, even during those early implementation projects. And then during early introduction, it will be important to support coordination to ensure the various tools and curricula in both HIV prevention and family planning programs are efficiently updated. So a clear understanding of those review cycles and timelines is important. And for training, pre-service training may also be considered as a rapid way to expand training. So now I'm going to turn over to my colleague Danny to talk through the procurement side of our analysis. But I also want to leave this group with a question and welcome thoughts in the chat or when we open up to discussion after. So we're interested in understanding and hearing from you on the major barriers to integrating HIV prevention and family planning M&E systems in your settings and programs. And what global and country level platforms or mechanisms, so technical working groups, global M&E initiatives such as FP 2030, can be leveraged to bridge these M&E processes for the DPP. And now I'll turn over to my colleague Danny to bring us through procurement.
Thanks, Danny. So my name is also Danny Edwards, Senior Manager at CHI, working with Danny Reza and the wider DPP consortium at understanding these system challenges in DPP introduction. First, thanks again to everyone for the opportunity to share some snapshots of our evolving work here. And just a reminder that in this work, we're like really in listening mode. So your input and comments and perspectives from the family planning space will be really valued as we continue to develop our thinking. Next slide, please. So I'm just going to start by quickly situating the procurement work. So what I'm going to share in the time available is just a sliver of a broader analysis of potential challenges and opportunities in the procurement of a dual indication product, such as the DPP. As you'll note on the left, the larger analysis includes large HIV procurers, such as Pepfar and the Global Fund, large family planning procurers, such as UNFPA, USAID, a closer look at a likely country procurer, the South African government, and a dive into the opportunity presented by social marketing organizations. This whole piece is contextualized in the frame that the DPP, as the leading edge of MPT development, can pave the way for future MPT procurement. For each of those procurers, we dive into cross-cutting issues, so things like coordination, packaging, for example, you can see on the bottom left, and then also identifying procurer-specific issues such as regulatory expectations, process considerations, policy considerations, for etc. On the bottom right. Today, I'm going to focus in on two things, and you can see these on the top right. Two cross-cutting issues, supply security and evidence needs, which have already come up in the discussion a little bit today. And then I plan on giving more of a spotlight focus on the advantages and challenges of social marketing organizations as a channel for DPP procurement. Next slide, please. So moving on to cross-cutting issues. The two cross-cutting issues, and there's more than two, I've called out for today's discussion, supply security and evidence needs. Really interested today in getting the take of people around these concerns from the perspective of family planning procurers. So first, supply security. This was well noted on one of the questions that was raised in the chat earlier. We do know that at least in the early years of DPP introduction, there'll be one manufacturer of the DPP, Adherence. And we also know from HIV experience, but also certainly I'm sure in family planning experience, certainly for government and likewise for procurers, that might be an initial concern. It definitely is true in the HIV space. It might particularly be the case in the contraceptive space where procurers are used to multiple alternative suppliers of contraceptive products. So actually as part of future work, CHAI will also be digging into, under the DPP consortium, some supply side challenges for the DPP to kind of flesh out some of those challenges. So just noting here that this initial period of product introduction also needs to be a critical learning opportunity to better understand real life demand and the relationship of supply alongside other challenges. We note that ultimately close attention needs to be played to this dynamic of supply versus demand to ensure that there is enough lead time to bring additional manufacturers online and the interventions to support that. Moving to the right-hand side, evidence needs. It's certainly true of large global procurers, but also true of procurement more broadly, that procurers set a particularly high bar for evidence needs. So alongside clinical trial effectiveness and evidence of demand for a product, this will include elements such as cost effectiveness and market size. And I think I'll just take this opportunity to respond quickly to one of the questions that I already noted in the chat. Yes, the consortium is engaged in cost effectiveness modeling of the potential costs and associated health benefits of this product. CHAI is taking forward that work with NYU. Unfortunately, we aren't quite ready to share results as that work is in progress, but we really look forward to being able to share initial results of that modeling in the coming months. Those last two bullet points, potential market size and evidence of demand, is why I'm just going to call out again the initial early adopter profile of the DPP. So this was discussed in the earlier session with Barbara and Jessica, and well noted the feedback from the group initially on the focus also needed on AGYW. But it is certainly possible that the DPP will be positioned as a relatively niche product at first. So women aged 20 to 40 already using combined oral contraceptives or PrEP or neither. So it will definitely be important to secure the perspective of procurers on potentially lower initial volumes and lower initial limited potential for economies of scale. Some procurers might be more resilient to those questions than others, particularly during product introduction. Which quite neatly leads me to the spotlight I selected for today, social marketing organizations as a channel for DPP procurement and delivery. So if you can move to the next slide. So again, would really value the insights and views of the group here. So we know that social marketing organizations can be nimble, responsive, and have been very successful in supporting a diversity of products, delivery points, etc., in the reproductive health space. So they can be particularly well positioned to deploy differentiated approaches to reach niche consumer profiles and population segments. And we also know from early DPP analysis that due to their connections with and ability to access the private sector and the stated preference of some groups of young women to receive reproductive health needs through private sector channels such as pharmacies, that social marketing organizations should form part of DPP introduction. So on the right-hand side, we note some advantages for consideration. That these organizations might be well positioned to target the niche consumer base of the DPP I just mentioned. They might be more resilient to lower initial volumes and questions connected to macro level cost effectiveness of the DPP. And we've noted some challenges as well, but these will be challenges in the public sector. Some of them have already come up in the chat earlier. Accessory questions of the support needed for training, for licensing, to Danny's earlier presentation to ensure that monitoring and evaluation and reporting are well integrated. So food for thought, and really appreciate reflections here. And the question I guess I wanted to get reflections on from the group, and I can see already that there are participants from social marketing organizations here, which is really great. What special advantages, or conversely, what special challenges might there be in social marketing organizations as procurers and deliverers of the DPP? And how might those differ between different social marketing organizations and approaches, for example, DKT, MSI reproductive choices, etc. So really happy and excited to dig into the discussion. I think you can move to the final slide. Thank you.
And I think just to start off the discussion, this was a question that Danny already started to answer from Ravina Chaudhry from MSI Reproductive Choices, who asked, when the product is in the system, one challenge will be to see where it sits within the public sector, keeping in mind that SRH work and HIV work is often siloed, as you said in your presentation. Efforts will need to be made to ensure that it doesn't fall through the cracks. Is there modeling to show the health benefits? And I know that Danny already spoke to some of the ongoing modeling currently going on as part of this project. But I think just to speak to the first part of that question, as you can see, we're looking across both HIV and family planning systems to think about what systems from both sides will need to be used and bridged. So one area, for example, is that family planning M&E systems really use demographic health surveys quite well for understanding the method mix. So again, including the DPP in those types of platforms will be really important for understanding the role in the broader family planning method mix. And then kind of speaking to the question about different stakeholders, I think as Jessica had noted in the previous discussion, oral PrEP programs are expanding very rapidly. And in some countries, family planning channels are already being targeted for expansion of PrEP delivery. So I think progress on that front across different countries may determine and inform where the DPP sits, and that might differ across different countries. So in terms of where indicators actually sit in M&E systems and under HIV or SRH or integrated systems as they evolve, I think that will be a question that can be explored further depending on the specific country introduction priorities. And Danny, this next question in the chat may be one that you're able to speak to briefly. And this is from Soumya Rao from the Population Council, who asked, could you comment on if you have reached out to actors in the HIV space as well, I think referring to procurement, say Global Fund, UNAIDS. What reactions have you received from them?
I think that's a good question, and so far the procurement analysis has really focused on landscaping the different potential challenges across evidence needs, expectations, market size expectations, and in particular like policy and regulatory challenges that there might be from the large HIV procurers. That's kind of a long-winded way of saying there hasn't been direct engagement on those questions, although there are ongoing conversations with, for example, Pepfar, who are anticipated to be an important early procurer of the DPP. And while I've got the floor, I'm going to take the next question because I'm pretty sure that's directed at me. It's the production capacity I can't speak to, but Viatris have at least indicated that they believe that there will be sufficient production capacity to meet supply for at least the first 3 years. That's something, of course, we're going to want to keep a close eye on, and these are some of the activities that are coming up under the DPP consortium of getting a bit better visibility around the market size and refining demand estimates. So once those issues start to clarify, then we'll look at, okay, well then what is needed, what support, what encouragement, what barriers might there be for additional manufacturers to come online to supply the DPP market, which could take different forms depending on that balance between supply and demand, the number of manufacturers that are needed to enter. So in terms of a direct answer to that question, when are other suppliers expected to enter the market? There are no current plans for suppliers beyond Viatris, but of course there will be in the future, depending on that dynamic between supply and demand. And I'm going to, I think the next one also from Megan Christopherfield. I think this is more a reflection than a question, which is fantastic. This is exactly what I wanted. So I'm just going to read it out loud for the benefit of the wider group. Interesting case for SMO role in DPP introduction and delivery. Would love to learn more about the current status of SMO HIV service delivery. For example, how integrated they are into Pepfar, differentiated delivery models, mobile care to key populations, etc., and what that might mean for early introduction learnings. Yeah, that's an important reflection, and taking those learnings from the HIV space into account will certainly help to inform our thinking with SMO delivery of the DPP. And again, from Ravina, thank you so much. The pharmacy channel naturally bridges the gap that exists between the SRH and HIV worlds. I see that as a real opportunity. Really well noted. And I think some of the emerging findings also from the earlier private sector analysis of the DPP, which was in Kenya and South Africa, again, reconfirm the preferences of young girls to access reproductive health needs at the pharmacy, which I think chimes well with that comment.
Great, thanks, Danny. And so I will just take the opportunity to elevate some of the input and feedback we've gotten from the chat on the M&E side. And then Danny, I will turn over to you for a last question I see in the chat. So from an M&E perspective, consider including into DHIS2 where possible. It will certainly aid in digital integration. This comment is very well noted and certainly came across throughout our analysis. I think one challenge from the product introduction perspective is that there may be some kind of lag between when indicators are able to be integrated into DHIS2 in the early phases of introduction where the DPP is not delivered across a huge number of sites. So one of the pieces that we're considering here is thinking about ensuring there is a very clear understanding of the requirements in order to integrate DPP indicators into those systems and minimize as much as possible any sort of siloed M&E systems to avoid overburdening already very busy family planning and HIV prevention providers. So for the last question, I think to Danny, and that we're certainly noting all of these questions in the chat for future discussion. Baker Magua says, given some limitations on how Pepfar funds can be used to support family planning programs, how will this be addressed when procuring the DPP?
I think that's an excellent question, and you've already touched on one of the important considerations in future DPP procurement. I'm going to have to give a non-answer to that question, other than to say that it's really well noted that typically, apart from male and female condoms, Pepfar does not procure contraceptives. And as part of early introduction planning, early sensitization, engagement, discussion with Pepfar is certainly taking place to better understand how Pepfar procurement will shape up. So that is noted. And I think we are on time. We have 5 minutes to wrap up. So I think, as Danny said, like, we are noting the remainder of the questions in the chat, and we'll be able to circle back. And would like to hand back over for next steps and wrapping up. Thank you so much.
Thank you, Danny and Danny. We really appreciate your time and consideration in presenting with us today.
My pleasure.
So I will be here to give us some next steps and really close out our really informative session here today. It's been just remarkably valuable to learn more about the development of the DPP and the considerations and challenges in market introduction. My name is Hima Patel, and I work at FP 2030 as the FP Integration Manager. And I want to thank all of you for joining, and give a special thanks to all of our panelists and facilitators for sharing their knowledge and ideas with us, and the AVAC team for coordinating this consultative webinar. We really believe that the DPP is the next MPT after the male and female condom to be available, and that's an incredible innovation in the field. We know that initial BE results are expected soon, and FDA regulatory decisions are anticipated to be available in 2024. End user preferences are going to be incorporated into product design and will continue to inform delivery and messaging, as we've heard throughout the webinar today. We're, in terms of the end users, we've heard a lot of really great questions and comments from all of you about who the end users of the DPP may be, and the importance of upholding informed choice in the context of contraceptive and HIV prevention method mix, especially as women are going to have different needs and preferences over their whole life course, and we recognize that. So it's really been valuable to hear from all of you about who these end users should be. But we recognize also that there is a lot of perceived stigma and bias that's going to need to be addressed in the healthcare delivery among providers with male partners. There's a great need to support women so that they can feel comfortable using the DPP. And as you heard from end users, ideally not need to be as discreet. We are hoping to expand the delivery of oral PrEP through multi-month dispensing, HIV self-testing, delivery in the private sector, and other differentiated delivery models, as well as bridging silos in the HIV and PrEP and family planning programs. And this is going to hopefully promote access to the DPP. Introduction planning and implementation research will continue to be co-designed with country stakeholders and many of you partners on this call. So look forward to us continuing to stay in touch with you all. We see this call as kind of a first step, a first way to kind of introduce the DPP to the FP community. And we envision us continuing to engage with FP stakeholders throughout this process as an ongoing conversation. So we are certainly open to setting up additional webinars and focus groups and things of that sort to address specific topic areas and keep this conversation moving. We will also be sharing the recording of this webinar after this call, along with a questionnaire where we will welcome any and all feedback, comments, and questions on the DPP. So again, a very big thank you to our partners at AVAC, Population Council, Clinton Health Access Initiative, and Beth Frederick as well. And we really are grateful for all of you participants here that have been sharing great insight, comments, and questions to help us keep thinking through the DPP. Thank you all so much. And a big shout out to Kate and Jessica at AVAC for all of the behind the scenes that has gone into making this event possible. And my great FP 2030 team as well. Thanks, everybody. That's all for us today.